how do you see the sort of landscape of treatment integration going? We have, you alluded to it, just endoscopic treatments. We have mitomycin hydrogel. We've got this photodynamic therapy, and then there's obviously, nephroureterectomy or segmental ureterectomies. And how is the sort of spectrum of patient selection fit? Obviously, renal function, disease grade, and burden all play factors, but how do you envision it playing out?
Well, I think there's still a lot of refinement going on in urothelial cancer overall in terms of our understanding of the disease. And a lot of that's based on genomics and biomarkers. So as we're learning more specifically about upper tract, what we find is that, say, FGFR3 mutations, for example, are prevalent in patients with upper tract cancers, whereas we don't see them quite so often in patients with lower tract or bladder cancer. And FGFR3 mutated high-grade upper tract cancers typically are associated with a more superficial phenotype, so a less invasive type of cancer, maybe not as multifocal as what we see with more aggressive tumors. And so there is sort of a strata of patients, even with high-grade cancers in the upper tract, that may be amenable to organ-sparing strategies, such as topical or ablative-based techniques. And so I kind of refer to those tumors as, instead of the wolf in sheep's clothing, it's a sheep in wolf's clothing. So it looks like it's high grade, but it actually may behave like a low grade cancer. So we're refining those things, I think, more and more. And in the AUA guidelines, we point to patients that have high grade upper tract tumors that are unifocal. They're not multifocal, they're papillary but not sessile in appearance. Sometimes they can be relatively small. They're not obstructing. And in that situation, you may have what's called the high risk favorable phenotype of a very early high grade cancer that potentially could be treated endoscopically in the same way that we treat high grade superficial bladder cancer with resection and BCG. But we don't have really a good BCG correlate in the upper tract, although you can give it through a percutaneous nephrostomy tube or in other ways. But I think that's where the new AUA guidelines, I would urge people to look at them because we have a very nice table there that describes these different strata of low risk, favorable and unfavorable, and high risk, favorable and unfavorable, that sort of points to certain categories of patients just based on clinical criteria alone that may fall into groups of patients that you can consider certain organ sparing strategies for.
Absolutely. Well, thank you so much for your time and for your efforts that are really advancing care for these patients.
Well, thanks so much for taking the time to interview me today and for talking about this important topic. And I just want to point out that this is a group effort. We've had a lot of people working in this space, a lot of collaborators at multiple different institutions. I would say not just everyone who's on the guideline committee who really did a lot of heavy lifting to get that done. We published that guideline in the middle of COVID, so we did everything by Zoom call. So I'm talking with you today by Zoom, but I got very used to a lot of Zoom processes during the guideline process. But there are also a lot of people who we wish we could have had on that guideline who are also incredible leaders in this field. And so just want to point out it's a team effort, and especially in rare cancers, it's really important to have people working together. And I think I really appreciate those relationships, and they're really fascinating and helpful for, I think, our patients too.